folks, this is not working at all. Folks, we're going to be starting the plenary in about 2 minutes.
Losing my mind, catching my breath, living blind, or am I trying to get ahead? Well, I got these feelings, and they linger. When I reach out, they don't hang around. A trappy young player, losing your mind. A catch behind the veil, or a blessing in disguise. Move through time, punching out the places, day and night. Call it what you like. Call it what you like. Born on the fringe, now raised on the line, now bottom of the earth, now is where I used to unwind. Now laid up the chain, nowhere to be found. I've been away since I don't remember how. A trap a young player, losing your mind. A catch behind the veil, or a blessing in disguise. Move through time. For you and I've been turning pages. I flip through time, punching through the paces, day and night. Call it what you like. Call it what you like. Shift through time. For you and I've been changing places. Take my time, punching through the places, day and night. Call it what you like. Call it what you like.
Next to Trish.
Okay.
And, you okay?
Yeah,
Sorry.
yeah.
Good morning, everybody. Well, if you could take your seats, please, that would be fantastic. Thank you. For our opening panel, ladies and gentlemen, what we decided to do is to have a panel that really set the stage for the conference and was connected again to the theme of our conference. And that's why this panel on megatrends in global health is going to take a look at how do we deal with that twin challenge again of living on a sustainable planet where by 2050 we expect to have 9.3 billion people. And we are already, as we know, exceeding the carrying capacity of our planet right now with what we're doing. And how do we deal with infectious diseases, old and new ones, and then the burgeoning and increasing challenge of dealing with non-communicable diseases, which we know are even impacting low-income countries harder than high-income countries, leaving not only death rates that are increasing, but also people with disabilities that are going to affect countries in many, many different ways. We're also, of course, dealing with a political environment that in many parts of the world, not only here, countries are looking at becoming more inward and nativist. So we have four esteemed individuals that have decided to be here today, honored to be with us today, to share their views on these megatrends, and in fact, what we can do as a community to be able to deal with them. And what we'll do is our guests will make short presentations for 5 to 7 minutes, and then we'll get into a discussion, and then open it up to Q&A with all of you. So get your questions ready. We have Dr. Mark Dybel, who is the Executive Director of the Global Fund, Dean Trish Davidson, again, who's the Dean of Nursing at Johns Hopkins University and an expert in non-communicable diseases, particularly cardiovascular diseases. We have Dr. Hester Klopper, who's the Vice Rector of Stellenbosch University, and Dr. Victor Zhao, who is the President of the National Academies of Medicine. And I'll ask Dr. Dybel to say a few words and start the session off. Mark?
Good morning. So I was asked to say a few words about where things are in the world, and I think the way you positioned the conference is right, because global health doesn't exist in a vacuum. It actually exists in the world of development, the Sustainable Development Goals, but more importantly, where the world is going. And while I understand people are concentrated on the U.S. For a variety of reasons, the global atmosphere is really important. And we are in a remarkable time of rapid change, geopolitical change, economic change, the traditional powers, economically, politically, everything's in flux. Ideas and people are moving at a faster rate than any time in history, and I think the ideas moving is hugely important. And the reality is, if you look back in history, whenever you're in a period of this kind of flux, this kind of major change where everything is uncertain, there are two pathways you can take. One pathway is to look inward and backward, usually with fear and its constant companion hate, or you can look outward, forward, hopefully. And in human history, we've tended to do the first for a little while, sometimes for quite a while, and mess things up pretty badly, sometimes really badly, until we start to course correct. But in today's world, we don't have a whole lot of flexibility if we start going in the wrong direction for too long. And what's happening around the world is very fascinating. So Europe is in a very interesting period. We have some big elections coming up. We had a very interesting election in the Netherlands. Obviously Brexit. France's election will be quite interesting. Italy, we had a change in prime minister. If you look to the east, China is really stepping up and filling voids. And so, when you have the president of China talking about globalization, climate change, green world, things are a little bit different than they were 10 years ago. So it's a very, very different time, and we sit within that. And we can either be afraid of all that or take the challenges, because I do think there's huge opportunities. I was on Capitol Hill the last couple days. I just came from London with the Secretary of State for DFID. And there is an opportunity here, but we have to see the big picture if we're going to engage. And if we're just kind of pushing on global health and global health issues, we're not going to get very far. We actually have to see where the world's going and how we fit in that context. And so I think the theme of your meeting is quite good. We certainly need to continue to make the case around infectious disease itself and the humanitarian piece. We should never lose the humanitarian piece because it's hugely important. And by the way, a lot of leaders react to that. You know, most people don't go into politics because they want to fight political battles. Some people do. Most people go into it because they want to do something important. And they don't get a whole lot of opportunities to do something important. So if we can frame opportunities in a big context of things they can achieve, because they have a lot of problems. Everyone comes, I know somewhere you're on the Hill, as soon as you left, someone came in with another problem, and after them, another problem. What they're looking for is solutions. So how can you solve big problems like ending HIV, TB, and malaria in our case? And that resonates really well. I mean, when you can tell a leader you can be the policymaker that drives towards a world that eliminates malaria and tuberculosis that have been around literally since recorded medical history, that's pretty exciting to them. And they grab onto that. Vice President Pence, when he supported PEPFAR reauthorization, stood on the floor of the House and said, we rarely get to stand up here and save millions of lives, and this is one thing that can. So if we're going to save money, let's save money elsewhere, but not here. So these big messages, these big things, if you can show it's doable, if you can show the results, we should never lose sight of that. But global health, again, doesn't sit in isolation. And so one of the things that's resonating really well in Europe, although a little less so here, is what you talked about in terms of population growth. If the population of Africa doubles in the next 20, 30 years, which is projected, if there isn't education, health, economic growth, what do you think is going to happen with those people? If you think you have a migration refugee problem today, look where the world's going to look like in 20 to 30 years. And here Secretary Mattis is quite good. I mean, he's an excellent advocate for development and for global health. And I would say that we need to bring more and more of the people from the national security apparatus, the defense apparatus, into the conversation. They are some of the best advocates and most effective, because when we go up and talk about global health, doesn't really impress people, because that, of course we'd say that. When a general goes up, or when a CEO goes up and says, look, I need healthy, educated people to work for me and to buy my stuff, so invest in this area, that matters. And by the way, I'm not just talking about the countries that are high income. This matters in low and low middle income countries too. When a CEO goes into the head of state in an African country or an Asian country and says, you need to invest in health and education, they listen to that. And so widening how we talk about what we're doing and why, focusing on the humanitarian, but bringing in those key pieces about national security, growth, and economics, and saying if you want the world to be safe, secure, and prosperous, we need health and education. And that plays pretty well. And we need to actually, I would say, get more data on this. We have some data, but we don't have enough. I mean, it's great to have Secretary Mattis talking about it, but we need data. So I'm actually cautiously, more than cautiously optimistic, but I'm also usually optimistic. We wouldn't have started PEPFAR if we weren't optimistic. But I actually think we're in a position where if we're careful, smart, strategic, we can actually have tremendous opportunity in this moment of challenge and actually tip towards the looking forward, outward, hopefully, because I think that's where most people want to be. And if we do that, I think we can make tremendous progress.
Thanks so much, Dr. Dybel, for outlining the importance of addressing the challenges and the opportunities. And so just in my 5 to 7 minutes, I thought what I would put out there is what I see some of the megatrends in global health and things that we have to consider. This is one of my all-time favourite slides from the Australian, the Bulletin, but you know, I take great comfort thinking 60 is the new 40, and I think many of us can do that as well. But if you think in many developed countries, 1 in 3 children will live to be 100. But those trends are happening across the developed world. And due to much of the success of the management of infectious diseases, we have people living longer, and of course we need to address the increasing burden of non-communicable diseases, many of which are related to factors such as smoking. But also we have to consider in many areas of the world, there is limited infrastructure to address NCDs. This is a slide which was taken a year ago when the only radiotherapy machine in Uganda stopped working, which serves 30,000 people. So basically, I think this is a call for us to get out of our disease-specific silos to think about more about the health system and how we address health across the lifespan. The other point that I just wanted to develop from Dr. Dybel's comments is this notion of a new world order. What is real facts? What is real truth? And the fact that geopolitical instability is a factor of everyday life. And many non-state-based actors are implicated in this. So it makes many actions of traditional diplomacy and very, very challenging and difficult. I think, again, as the world enters into an anti-globalization phase, we have to recognize that there has always been mobilization of populations, but this is accelerating both forced and involuntary migration. And of course, we cannot deny this huge number of displaced personnel around the world, which is in almost, getting towards 70 million. And as Dr. Dybel mentioned, this is going to increase. And this has real implications not just for the number of people that are displaced in camps. Many of us who do work around the world see what has been the impact in Turkey and Lebanon and other countries of just this rapid influx of several million people. What is the impact on healthcare services? And how this fuels a lot of nationalistic fervour and distrust and operating in an environment of scarcity rather than generosity and being open. The other really important point that we have to address is health of the planet. And particularly in the United States at the moment, as the EPA is truly threatened and people debate the issue of global warming. Each of us know in the areas that we work, these are very real factors that impact on health, not just on a macro sense, but also very much in the lives of individuals. The Lancet Rockefeller report has really set an important agenda for how we address this, but how do we decipher this information into terms that people truly understand? And for many, global warming and climate change is an esoteric, diffuse concept, but if you're living in Tuvalu in the South Pacific, these are very real issues. Australia, this last summer, India had the hottest summers on records. These are real issues in both developed world and lower middle income countries. And also, Dr. Dybel talked about, climate change, and this is people's view of climate change. And certainly in China, they have done probably much more than many other countries to address climate change. But many of the impacts of climate change are much more slow and insidious and truly impact on health. I think another really important issue for most of us is addressing health disparities. And again, as Dr. Dybel mentioned, that's what kind of got most of us into this, and probably what has got many of us, of our colleagues, into public service. But this is a real issue. And again, I just really want to emphasize the importance of addressing the health and well-being of women. The Women's March across the world has underscored the importance that this battle is not won, that in fact many health inequities continue to increase, while 1 in 3 women across the world is exposed to some sort of violence. We really need to address the social, political and economic implications for health for everybody in the population. And again, this is a slide just from Guatemala recently, where in the United States people think that migration to the US is all from Mexico. The human rights abuses in Guatemala, Honduras and other countries are real call to action for us to truly address health and well-being. And again, as we enter into the burden of non-communicable diseases. The majority of evidence that we have to treat women with cardiovascular disease is derived from Caucasian white populations. How is these drugs applicable to black men living in Africa or black Indigenous women? We're not sure. And of course, I think what is hard for many people to understand, and this is one of my favourite slides from Lisa Cooper at Johns Hopkins, which really makes us think about if we're going to achieve equity, and if that is our goal, we have to have tailored, targeted solutions. So the one-size-fits-all is not going to achieve the goals that we look forward to. And my last comment, I think, is one of the important things that we really need to address in terms of global health is addressing health system strengthening and the healthcare workforce. Ebola taught us many lessons of the failures of not having a strong healthcare system. And I think we need to really look and learn from many of these issues. And I can tell you, in many areas of the United States, Europe, Australia, we have poor healthcare systems that are not coordinated, and we know from data from the United States, just spending more money is not going to make a difference. We need to look at coordinated healthcare systems and improved healthcare roles. So again, they're the key issues that I think we need to be thinking about in the context of this meeting, and I look forward to being able to discuss them with you over the next few days. Thank you.
Good morning. Good morning. Great, thank you. At the National Academies, we're here to serve, and our great passion is to be able to work with all of you, US or globally, about issues of health, of course in science and engineering. My first slide really just simply says who we are. For those who remember us as the Institute of Medicine, we're now the National Academy of Medicine. And the three academies under the reorganization come closer together and overseeing all the programs of the academy. So from now on, you won't see an IOM report. You'll see reports from National Academies of Engineering, Science, Engineering, and Medicine. And the Health and Medicine Division of the NASEM is responsible, in fact, for the global health aspects of what we do. Now, many of you know about what we've done, and I just want to give you some background in teeing up what I'm asked to talk about today, which is what do we advise the US government to do? As you know, the IOM has written some really important reports, including 1997, America's Vital Interest in Global Health, and 2009, US Commitment to Global Health. These were reports that, in fact, particularly 2009, they were presented to the President Obama for his strategy or directions in global health. And as you can see, what I've listed here are some of the actions that might have come out from the report, including the formation of BARDA in 2006. We can't claim all the credit for it, but certainly in those reports is the issues of surveillance, issue of R&D and research, and importantly, of course, the issue of commitment to global health, as well as growing capacity in different countries. We also were responsible in 2013 for the reauthorization of PEPFAR, in which the Congress mandated that we conduct a study to assess its performance and effects and the direction of PEPFAR. As you can see, that we have certainly talked about going from emergency relief to long-term strategic planning and capacity building. And of course, as you all know, PEPFAR was reissued. Now, I think it's an interesting question that we faced, which is what's happened since the 2009 report, the report in which we talked about the landscape in global health and where to go. This is just a collection. You already heard from my distinguished panelists about so many things going on that's really changing, even in the short 8 years since we last said the report. The issue of increasing infectious disease outbreak, pandemics and epidemics, the rising NCD burden, antimicrobial resistance is now becoming such an important issue they will have to face with, question on unfinished business, TB, malaria, HIV, to all the new challenges. You heard about planetary and health and One Health. Of course, the commitment of SDG to universal health coverage, importance of quality of care, structure and financing of global health, and of course, importantly, for us, what we would tell the new administration about the direction of global health. This sets the stage for we started in anticipation of a new U.S. administration, U.S. president, and we've created, in fact, the committee to look at the future directions and future role of the U.S. in global health. And this is the charge on which we gave the committee. I want you to focus on the bottom two, which is how challenges, actions, and plays have evolved over the last decade, and of course, recommendation how to increase responsiveness, coordination, and efficiency, both within the U.S. government and across global health field. So this report, I regret to tell you, is not ready. And, I was hoping, and I know that many of you would have liked for us to tell you the specific recommendation. But in compliance with the Academy's policy, as well as in compliance with the Federal Advisory Commission Act, our report is still undergoing review and therefore not ready. But nevertheless, what I would like to do is just share some thoughts with you about, at least my perspective, what the major issues could be. So first of all, the committee. You won't have time to go through the entire list of people, but I'm sure you know many of them. And in fact, there's an afternoon session today, which in fact will discuss a little bit by the committee members, some of the committee members, of some of the deliberations. But importantly, this committee worked really hard. And I'm sorry it's not ready right now, but it's gone through an enormous amount of work, reviews, public hearing, all the way to having a report ready to go into review in February, and is still undergoing revision. Many of you who publish papers know how sometimes you're going to have to do multiple revisions. In our case, we usually have 20 reviewers, and you want to make sure that your report is credible, balanced, and of course, evidence-based. So right now, we're looking at release in about a month from now, and maybe this is a good way to say I'm giving you a preview or a trailer so that you can get anticipation when the report comes out to read it and to see whether we can take actions on it. So what are the issues that we could think about? These are my own opinion, not of the committee. I would say that committee could think about these issues. Importantly, of course, global health governance. So much been discussed, particularly around the issue of emergency preparedness and the many, many crises that we have faced. Global health security, from pandemic preparedness to biosecurity to antimicrobial resistance. The issue of the future of PEPFAR, malaria and TB, maternal and child health, and the rising epidemic of NCD, cardiovascular and cancer, which if you look at the amount of dollars spent globally on those areas compared to others, it's a very small, tiny fraction. Something needs to be done addressing that. I'm sure Patricia likes me to talk about that. Financing global health. What's the U.S. government? What about domestic financing, mobilizing resources to strengthen local health systems? And of course, for us, the leadership and coordination of the U.S. programs. I think there are many opportunities that committee could think about, including from the issue of vertical to horizontal, building capacity and strengthening health system, rethinking the way we finance health aid to other countries. The question is, so many now, the lower income countries are becoming more enriched. The question is, what is the commitment of those governments to their own health system? Harnessing innovation technology, such an important issue right now in solving many problems, particularly digital technology, digital health infrastructure, and leverage multilateral organization, private sector, in resource, in capacity, in expertise. Now, if one were to take a look at where we are in the U.S., the funding from U.S. has been quite stable. You can see in both slides that over a number of years, it's been hovering around $10 billion. And in fact, the slide on the bar on the left side shows we usually actually get a little bit more than we request. So that's the good news. But as you all know, we are faced with some very uncertain times that I believe that Keith has passionately talked about, and importantly so. So far, we do not know the political direction, although that's not to say there isn't one. I say the big concern of us, of course, is the reinstate and expansion of the Mexico City policy. If implemented really aggressively, about $9 billion of $10 billion of US global health dollars could be at risk. And of course, the skinny budget that which we have been able to see so far from our President Trump proposed budget is high priority for defense and reduction in foreign aid. Now let's take a look at 2018 budget. NIH, huge cut, 18% cut with elimination of the most venerable and important center, the Fogarty Center. CDC cut with 20% with reduction of the Prevention and Public Health Fund, which is $1 billion. Of course, that's going to jeopardize the global health security agenda that has a 5-year track. Of course, HIV, TB treatment, and of course, global immunization. State Department cut by $20 billion, 37%, which USAID is 1% of budget. EPA and NOVA all faced with a proposed cut. Now, there is some encouraging news. Many of you know that, in fact, one important thing that many of you asked for is an emergency response fund to, in fact, public health outbreaks. That is, in fact, in Trump's proposed budget. And the Department of State, at least the budget says, will provide sufficient resources to fulfill the $1 billion US pledge to Gavi Vaccine Alliance, and also to provide sufficient resources for PEPFAR and the others. Now, all this is, of course, a proposed budget, and many of you know much has to be discussed. I think some people say it's dead on arrival, but certainly I think Congress, as you have heard, we have many friends in Congress. I think we're up to, of course, many discussions going forward. But let's not take our eyes off the 2017 proposed budget, which is right now being in play, which is in order to increase more defense funding, there will be proposed $600 million cuts in the various aspects of PEPFAR, Global HIV Fund, FEP, and of course, you can see that family and reproductive health. Now, for us, we strongly believe that it's important that we need to continue to invest, certainly in the US, in global health. We are 1/3 of the total spend in terms of development assistance. It is, as you said, a moral imperative. It is a national security, economic security, and perhaps this is going to resonate better with the current administration, and of course, it's diplomacy. So let me just say one word about this. If you look at pandemics alone, and that's only a small slice of what happens in global health, we, in our last report on global health risk framework, chaired by Peter Sands, estimated that about $6 trillion of cost in the last 10 years and about $60 billion a year per year of economic loss just from pandemics alone. Bill Gates says that, in fact, if you have a fast-moving airborne pathogen, it can kill more than 30 million people in less than a year. And Larry Summers have shown, at least estimated, that, in fact, the amount of economic cost of the global pandemic is equivalent to climate change. And if you look at the World Bank, a repeat of 2018 flu pandemic alone will lead to a 10% reduction in global GDP. These are astounding numbers just on pandemics alone. You can imagine what we talk about in national security and economy, and perhaps that will resonate with those who are particularly interested in national security. So I would say that in my last slide, there's a need for us really to support global health, and perhaps the opportunity now is to rethink about how we can evaluate and rethink global health. I think a lot more accountability. Perhaps we need to look at more results-oriented for the new administration. Certainly, it should be support that's responsive to changing priorities. It has to be dynamic and resilient. It has to facilitate country ownership, and of course, importantly, to leverage other resources and innovations as well. So with that, I would just like to say that I'm sorry we're not ready for a report yet, but there will be good discussion at the afternoon workshop. But I think all of us strongly, strongly believe, and I certainly do, and I'm with you all the way, that we will do our share in order to assure that our investment support global health continues and continues in the strongest way possible. Thank you.
If the IT person is around, please come up and see where Dr. Klopper's slides are. Thank you.
Yes. So I'll kick off in the meantime, and I wanted to say greetings, and I wanted to entice you with some photos of, there it is, of what I believe oh, there it's gone again. Let's try again. Okay. Wanted to entice you with some photos of what I believe is the most beautiful city in the world, a town called Stellenbosch, 45 minutes from Cape Town. And then also one of the most beautiful campuses, Stellenbosch University. But more so, also bringing you greetings on what is World Health Day today. And the focus today is on depression. So I wanted to start off by saying, if anyone feels isolated during this meeting, please, let's talk. Keith has asked me to speak about megatrends specifically related to, from an Africa perspective, and I'll try to highlight some of those that I do think are important. First and foremost, the theme of this conference, healthy people, healthy ecosystem, I think encapsulates the most important premise of the global agenda as it relates to health. We have seen over the past two decades that the international development of the agenda prioritized funding to HIV/AIDS, maternal and newborn and child health. And yet we have seen in most of the African countries that this still remains a huge challenge, and specifically more so in my own country, where we see the incidence of maternal and child mortality remains at the highest end around the world. So with the adaptation with the SDGs goals and targets, it really provides us then with a basis to now look at a broader agenda. Focus, or let me say, Goal 3 specifically focuses on good health and well-being, and the other 16 one could interpret as the social determinants of health. Very important in terms of moving forward on the global trends is, and I will end later again on the global trend that I think is so important of interconnectedness and collaboration, where we will not continue just to speak about health, but it is interrelated and part of the global agenda and very inclusive in terms of what we want to achieve. Some of the trends that I want to highlight is specifically the global change impact on Africa. I will not discuss each of these, but I want to highlight some of those aspects. We have seen huge changes in weather patterns around the globe, but specifically in Africa, where there's flooding on the one end and then droughts. We have seen one of the most severe droughts in East Africa in years. And most probably not known to everyone is that Cape Town is specifically experiencing one of the worst droughts in 100 years, to such an effect that in media it states that we only have 100 days left of water. So what we see is that observable effects of climate change and water resources in Africa, including the changes of rainfall, drying up of rivers, and melting of glaciers, is a reality. And I've just included there a slide of what the glacier on the top of Mount Kilimanjaro looks like now, if we compare it to 1912. And that photo was in 2009, and it's even deteriorated more. Continued impact in terms of climate change on Africa is, across Africa, the landscape is changing. And we see that, for example, the droughts causes heat stress and flooding, leads to a reduction in the crop yields and livestock productivity. According to Oxfam, 12 million people at the moment in Ethiopia, Kenya, and Somalia are in dire need of food. If we then think about the impact on human health, climate-sensitive diseases and health impact can be high in poor countries with very limited resources. And what we've seen is, for an example, the severe heat stress that leads to a result in terms of how health is affected. The reduction of air quality has had a huge impact in terms of women's worsening respiratory diseases. And then the challenge in terms of maintaining and securing food security, specifically looking at the huge impact on the rates of malnutrition and how it contributes to poverty. Another one most probably that I want to highlight is in terms of vulnerable populations, where women, children, and elderly are more vulnerable due to the climate changes in Africa. Women laborers often experience additional duties as caregivers, as well as from societal responses to climate changes, and that they actually have to then take up what happens after this male migration to go and find work. And the water scarcity places an additional burden on African women, who often ends up working miles to collect water. The other global challenge that I think we will be faced with, and there was some reference to this already, is the Africa population. And what we see in Africa is the continuous rapid expansion, and the prediction that by 2016 we will see Africa with 2.8 billion people. The World Bank report, Africa Demographics Transition, is it divided or a disaster, notes that the demographic change, such as population growth and a reduction of the number of dependent youth, can have a deep impact on the countries across the continent's economic growth and the well-being of families. To note is that the report lays out an agenda for African countries to increase the likelihood of capturing potential social and economic growth, so that we would be able to have timeous interaction and intervention. Already noted is the aging, and by 2020 the projection is that we will have 10% of the global population will be 65 years and older. Although I know this is the trend in the developed world, I do think that it's important to note that Africa is also affected, and specifically with reference to the fact that it leads to an increase of people suffering from chronic and expensive to treat diseases and disabilities, straining the already challenged healthcare systems around Africa. Technology is a trend that I think will definitely impact on health in future more than we most probably can ever anticipate it. The accessibility to quality healthcare is rising with increased connectivity. Specifically in Africa, what would be important is the applications that could be used by using mobile technology, moving towards mobile health, diagnostics via video conferencing. And then of concern is the whole development of robots, as we've seen in Japan, for example, providing basic care. And the consequence of that, where some of the needs of taking care of those populations are disappearing from curricula of healthcare professionals in some of these countries, because it's not seen as being important. So in a recent study which surveyed over 24,000 consumers in 29 countries found that emerging countries are most inclined to develop markets in owning and wearing devices that can actually track their health. And that's the way that we need to go, because anticipation is that Africa will not grow into some of the technologies, but that there will really be a leapfrog into those technologies as it becomes available. I know we often think, well, 3D printing and the impact of that on global health, and it might not just be a bad thing overall in terms of the shortage of organs around the world. Looking at some statistics available says that 1 out of 5 people on waiting lists in the United States and 1 out of 30 in China waiting for transplants. So on the long term, one might say that 3D printing might help to increase the supply. Another trend that I do think is critical in terms of where we will be moving with health is genomics and the genome-related technologies that can contribute to improving global health equity. To do so, the genomic health divide must be kept in check so that we would be able to provide that technology around the world and to all the populations that would be in need of that. I will not do justice to Africa if I don't conclude with what I believe in terms of challenges that we are faced with and that should be on the forefront of our agenda. And that is speaking to the universal access to healthcare. In the light of soaring healthcare costs, the question remains, how is Africa going to afford this? We see that affordable care and the rising costs is just on the increase. So one way that I believe we should be able to do this is through collaboration, fostering the more effective North-South and South-South collaborations. We've seen on the continent of Africa very influential networks being established, and I think that the CUGH could be one of those in forming some of those regional platforms to promote global health. Another one is ARUA, which is research universities getting together, driving the research agenda. ROOF Forum that looks at agriculture and how that relates to all the other social determinants of health, including health. We've also noted that tomorrow there will be a meeting with AfriHealth, bringing together those that speak specifically to education of the health professions in Africa. So moving towards then a wellness and fitness focus will be critical in Africa, and I think we have not started to really penetrate that market in terms of a shift to wellness. And want to highlight what Dean Davidson has said, the challenge in terms of the workforce, where the world will be short of 12.9 million healthcare workers by 2035 is the projection. At the moment, we're looking at 7.2 million. So encouraging developments happening, for example, that more countries have increased to increase their health workforce, progressing towards the basic threshold of at least 23 health professionals per 10,000 people. Yet we see that 83 countries are below that threshold, and most of those are in sub-Saharan Africa. So all countries are urged to heed the signal of shortage. For example, that developed countries, and it's scary to know that 40% of nurses will leave their health employment in the next decade because of the aging of the profession itself. With all these challenges, I want to say there's huge opportunities for us. And I think it's in a timely manner, getting together, speaking about this agenda. The time is now for us to act. Thank you.
Thank you very much. Thank you very much. If any IT people at the back, if you could bring 2 more of these mics, that would be great. Thank you very much. Thank you very much for your presentations. Those were outstanding. I'd like to ask Mark, you mentioned the very important issue of having data to be able to support, to be able to influence politicians. We're living in an era right now where there's a big anti-science move, an anti-intellectual move. What do we need to do to be able to overcome that anti-science, anti-data, anti-fact bent that affects people's decision-making on everything from climate change to other aspects of the challenges we're talking about?
I'm not sure I would entirely agree that we're in an anti-science, anti-data. There's a big difference between public policy, public discussion, and what happens beneath the discussions. And I actually think there's more and more desire for data. The problem is we're not particularly good at couching data for policymakers. I mean, I'm actually working on this right now. I mean, we create reams and reams and reams of data, but they're not structured for policymakers. And I have to say, the briefs I've seen on how we're going to influence Congress and the administration aren't going to work at all. They're not what they're looking for. And I would just say again that, you know, and I learned this when I worked for the State Department, every meeting you go to and ask for money, they have another meeting as soon as you walk out the door of someone else asking for money for something else. And if it's just listing problems and just listing, you know, here's data showing big problems and here are these 50 studies that were done, it's not going to go anywhere. How you structure data for policymakers is really important. And, you know, I've long believed that every NIH grant should require a cost-benefit analysis within it, or what impact are you going to have, or what's the cost of not inaction. And we're not good at that. We don't position the data in a way that the policymakers want to look at. I would also say the data aren't particularly strong in a lot of places, and so it also relates to how we're going to respond most effectively. If you have problems are all over the place. They want solutions, so you have to be able to use the data and collect the data so that it can be used, but it has to be used by every person. So we are terrible at collecting or asking data that a community healthcare worker would use in their daily life. We focus on reporting. And so, not surprisingly, community healthcare workers or nurses or doctors, that's an added job. They don't have time for that. So the data they collect is often bad because they're not inaccurate because they don't have time for it. So we're not very good at driving data for decision making from a community healthcare worker to a minister of health to a global level. And if we don't get better at not only data for decision makers, but I mean decision makers day to day, we actually aren't going to get the type of data that big policymakers want. So I actually think there is a huge appetite for data. It's just how we position it, how we couch it, how we use it. And when we're kind of in a data-free zone, people can throw in whatever they want. And if we can't respond in kind, we're not going to do very well. But I actually, you know, what people say in public and what's on the front line of a paper is very different than the policy conversation. And we can win the policy conversation.
So Victor, how are we going to overcome the alternate fact universe? And what advice can you give to the audience here, mostly from academia, to be able to support the work that you do at the National Academy, the outstanding reports that you produce? How are you going to sell this, or should it be sold, the information of the report that's going to come out soon?
First and foremost, I agree with Mark that science and evidence is the foundation of what we do and should be the foundation for policymaking. That's going to be critically important. I think the question really is, how do we get people to listen to evidence and science as the basis of decisions, response, etc.? I think we just need to learn how to communicate much better. There are really, to me, 2 audiences. One is the public, and second is the politician, right? I would assume that among us, we understand what we do. So at National Academies, we spend a lot of time thinking through this, particularly as what we do is science and evidence-based, and the question is, how do we be sure that what we do is actually have traction? First of all, I think for the politicians, it's really have to spend the time with them. Spend time, and you know, they have a lot of really good staff as well. And whatever is in the issue of politics per se, I think that they're open enough and to understand the importance of evidence and science. That's got to be the way. It's hard work, but as you said earlier, it's going to have to talk to your Congress, the administration, etc. And of course, the way in which we approach this will be critically important. As many of you said, it's not just simply pushing for the moral high ground, but understanding what makes them tick and what really would they listen to. Particularly since it's been said a number of times, messaging is so important, right? And I think if this administration is really interested in defense and what serves America great, we need to look at how important it is in terms of the economic and security impact. And I think almost all countries, to a large extent, understand that issue when you start talking about economic and security impact of global health. And of course, lives matter. For the public, I think it's really important for us to learn how to use social media and others and be a trusted voice of the community. So first, gain their trust, and I do, many of you, of course, you know, who do such important work in universities, have that kind of voice. But also, however, sometimes those voices are being drowned out by maybe the post-truth through social media. So we're going to have to learn how to work with that aspect of it and communicate better in that regard. At the end of the day, what we believe at the Academy do is we must stand up for evidence, and the reports that we have given, such as vaccine safety, etc., those evidence will always speak up for it. We want to avoid getting into non-science political debate, because that's not helpful for people like ourselves. We want to, however, get into the debate when it comes to what's evidence, what's science. So I think we need to learn to do much better, and let's face it, many other industries have learned how to do that effectively. We have not done it as well, and we should. But I agree with you, Mark. Data and evidence is the base of what we do, and we just have to learn how to communicate.
Trish, you've been you're an outstanding communicator, both in Australia as well as here, and you've been really innovative in what you've done and how you have done it. And Victor made a good point. We not only have to speak to politicians, but the public moves the political. So how should academia be more effective at communicating with the public?
Well, I guess I learned this lesson probably 20 years ago when I was trying to sort of set up heart failure clinics. So I was sending all of these New England Journal articles to the minister, and it didn't happen. Then there was one phone call from a constituent that just kind of changed the game, got the issue to a different agenda. So I think really communication more broadly, I think probably global health, we don't have the same constituency to have a voice, such as where people have been successful in HIV, breast cancer, etc. So I think it's really about communicating the issues. The other thing is, as Mark was talking about, where is the solution? And part of the solution, I think, for the US budget, and not just the US budget, for many healthcare budgets, is looking at the waste that occurs within our healthcare system. We know that there is just a huge amount of waste, but this is really driven by industry, by pharma, by a whole lot of other groups with vested interests. And we know, for example, at the end of life, being hospitalised does not provide very little benefit, but there's a lot of drivers to that system. So I think it's really important that we identify what are the messages, and that it's not just us, but our constituencies that have to have the voice. And within global health, that's a bit more challenging, and I think that's where we're at the moment, is that in the United States and other countries where there is this nationalistic, populistic fervour, it's about out there, it's not about in here. And I'm not sure, and I think we really have to work at channeling those messages. The security argument is a good argument, but it's also somehow if we lose just the social good and humanitarian aspect, I think we have a risk for the future.
I just want to agree with Trish that, and you said it earlier, we need to mobilize, besides ourselves, other industry and leaders to support this. I think multinational companies, CEOs understand it because they have employees everywhere. They need a market, they need a healthy market. And so certainly it's been my own experience that when you actually connect with many of the industries, and I'm talking broadly now, I think many people kind of get it. And we need to be sure that we mobilize their support. Rex Tillerson was previous ExxonMobil CEO, and in fact, their company provided a lot of support for maternal and child health, and I know that other companies do that too. So mobilizing the other sectors besides the health sector is critically important. During the time when Ebola was a big issue, of course, we all want to look for ways by which we're going to get more support. And of course, people like Larry Summers and others are enormously influential. So Larry organized a dinner for me with 20 finance ministers across the world during the World Bank meeting. And he gave me the opportunity to tell them about how important it is to invest in health, not just we're looking for more handout and more issues, but in fact it's economically important. And so I think we need to speak to others besides just the same people and being able to message it right. And you're quite right, Trish. At the end of the day, it is, of course, about human lives. But I think it's what you can couch the message in a way by which those decision makers are going to be receptive to the questions that we put forward.
Hester, Stellenbosch, from its lovely perch in the Cape, really lovely perch on the Cape, it punches well above its weight, being really a leader on the continent. What advice can you share with us in terms of how North American, Western institutions can collaborate more effectively in terms of communicating and working with the communication, the messaging coming out of African institutions? How can we be a better champion and a better partner?
Well, Keith, I'm not sure that I've got the answer to that, but what we've seen, in our country, in South Africa, is that we have had large campaigns on family planning, safe sex campaigns, which has not been successful. And what became very clear was about how do we do the messaging and how do we speak to communities so to really penetrate it. And you started off this morning by, when you spoke about the institutes and the organizations that need support, that there's a fact sheet outside. And one of those things that we've seen is exactly that one needs to provide very clear fact sheets, but that speaks to the issue at hand. Because we might go out and then as many people speak to the issue and the intention is good, but the basic framework of those facts, if those messages are different, I think it leaves it open for interpretation. The other drive that we've seen in one of the projects that we were collaborating with 5 countries around the world, and one of the countries was Uganda, and South Africa partnering with the Barbados, Jamaica, as well as Canada, looking at how do we prepare healthcare professionals to influence and strengthening health systems by making a difference in policy. And part of that messaging that became very clear to us, especially in the areas that we worked, was that sometimes we think about the decision makers, but there's somebody who influences the decision maker. And we found it very useful to get behind who are those influencers and really get them on some of the work that we were doing. And I think lastly I would add is to, and I agree with everything that is said about when we look at these messaging, including different sectors, multidisciplinary teams, but then ultimately including the voice of the community or then the patient. If they are not part of that in preparing that message, I think we are losing, and that's some of the lessons we've learned.
I'm going to ask you, each of you, to respond to a question in a minute or less. But I'm going to because we want to have time for everybody to have Q&A. So the question is this. One big challenge, one big solution to a mega trend taking place in the world right now in a minute or less. So please, solving the... They can do it, right? But we're going to give them a few seconds to think about that because they're very generous at CUGH. In the meantime, there are 3 mics. Please line up behind them. We're going to be very quick in terms of people responding to questions. I would suggest if there's more than 4 people behind a mic, we're not going to have time to get to your question. So, and we'll bundle them up. So we'll try to get through as many as possible. So, who would like to go first?
I'll take it.
Dr. Zhao.
Well, I want to talk about CEPI. That's an example of a great solution, at least an attempt solution for a big challenge, which, as you know, is forming vaccine for emerging infectious disease or re-emerging infectious pathogens. You know, everybody knows it's a market failure in the current day, and look what happened. You know, through a coalition of starting at Davos over a year ago, a coalition of industry, government, NGOs, civil society, academia, etc., when got together to say, we can do it. And of course, as you know, so far, $740 million pledged. You know, starting with now selecting vaccines towards 3 pathogens through prioritization, it's a step in the right direction. So if you ask me going forward, antimicrobial resistance, because one can imagine the same kind of argument being made by bringing together all different sectors to find solutions. The whole idea of creating a market, so-called market, incentive for market failure area, right? And different ways by which you can bring sectors together to find solutions. So I think that would be, I believe, a very exciting possibility.
CEPI, fantastic. Esther?
One of the challenges, most probably for the purpose of this panel that I want to highlight, I think, is a challenge in workforce and the challenges that we will be facing. So one of the issues that we've identified over the past 5 years was that what we would find is that the more we want to work together, the less it seemed that it happened. And more so, within my field, being a nursing professional, was the divide between nursing, midwifery, and nurses around the world, and how that's pulled up, and the isolation then of the profession from other professions. So one of the solutions that we hopefully came up with is an initiative started about 2 years ago called the Global Advisory Panel on the Future of Nursing and Midwifery, and the intent, and we've done this now around the world, getting leaders from different professions together to tell us what are those challenges that we are faced with, so that we can come up with a platform so that we can get those messages out in a unified voice and unified message. And I think it's those type of initiative really uniting us all, and then finding the solutions that we are faced with within the workforce. Challenges in terms of making sure that there would be enough numbers, the quality of our health professionals for the future will be an issue, because we can go with all the other trends, which is happening, but if we don't have a healthcare workforce that will look after the communities and support them in health initiatives, I think we are set up for some failure.
Thank you, Esther. Trish?
Well, I'm going to build from Hester's comment and just say that a solution to many of these complex issues is education. Now, education is kind of, germane to our missions, consortiums of universities for global health. And I can just see through my work and others, and I think probably Fogarty demonstrates this the best, is that if you invest in education, you are going to contribute to economic productivity. We know for education for women increases their health and well-being. And just at this challenging time, it's heartbreaking when we see in our institutions, particularly Muslim students that are feeling alienated, marginalized, and under threat. that it calls us to action to make sure that universities are safe and welcoming environments, that we keep the doors open to international students, that we advocate for those visas, which are hard to get, because I firmly believe that education is really important for empowerment and contributes to productivity of society. So I just think at this challenging time, for many of us as teachers, it just really underscores the importance of us promoting diversity, and particularly for low and middle income countries, to make sure that the opportunities in the United States and other countries remain.
Mark?
So a mega trend that's driving a lot of the political reaction, a lot of the problems in the world today is what is called migration. So two solutions: stop calling it migration because it scares people. Call it economic mobility. And the second thing, and this relates to health, one of the scary jobs is definitely scary to people, but one of the biggest issues relates to health. So the Maldives and Thailand, I think, have found solutions, are working on solutions. They understand that economic mobility is important. People coming from other countries is the only way their economies will thrive and survive, and this is what Chancellor Merkel says as well. But they need health care because they have to be healthy, or they can transmit, in this case, tuberculosis and other things. So what they've done is expanded their national health insurance, in the case of Thailand, to documented workers, but in the case of the Maldives, they're actually trying to extend it to documented and undocumented workers, which is not easy. So that's a massive solution. If people can actually see the national interest of expanding their health insurance to documented and even undocumented workers, then you start to change the fear of migration to an economic mobility, economic growth solution.
Thank you very much, Mark. Excellent comments by everybody. So what we're going to do is just, we'll bundle 3 questions, so the first 3 people in a row. If you keep your question to well under a minute, we'll be able to ask the panelists for their response. So on my left, I'm sorry, I can't see anybody with the lights, so please go ahead, sir.
Thank you. Richard Horton, Lancet. 4 excellent talks. 2 questions, one to Mark, one to Victor. Mark, you said that if you can show results, you'll do well. That sounds superficially very reasonable. Does that mean that the Environmental Protection Agency, Fogarty, and the National Institutes of Health have performed so very badly that they deserve the cuts that they're getting? And a supplementary to that, to what extent do you think that the leaders of global health initiatives, such as yourself, that have been spared cuts, have a duty to resist the rage against the global led by President Trump? And then to Victor, I enjoyed your talk a lot, Victor, but I can't reconcile it with a letter that you sent out on March the 29th under the letterhead of the National Academy of Medicine concerning making public statements about national policy issues. You wrote in that letter that you should continue to speak when you have the relevant evidence. But you then said this, and I quote, "It would not be consistent with our mission for the academies and the presidents to advocate on policy issues, whether for broader issues in science, engineering, and medicine, or on political, economic, or other issues." So if the academies do not see their role as being guardians of science in society, what on earth are you for?
Thank you, Richard. I'm going to go through the questions first. It's very difficult to hear. I'll try to repeat them. Yes, in the middle, please.
Hi, Ben Roberts, Johns Hopkins University School of Nursing. Thanks so much for some great presentations. I've got a very different question. It can be very overwhelming thinking about providing care for people in low-income countries who have so few resources to start with. But at the same time, coming from where I am in Baltimore City, I know I'm caring for people that in many ways, when it comes to health and education, their lives are resembling some of those worst conditions in low and middle income countries. So my question is, can you speak to the existential challenge of deciding whether to act more locally or more globally when there are health disparities everywhere? Thank you.
Thank you. And the last question?
This is Joe Tucker from UNC Project China. Thanks.
Sorry, you'll have to speak up, please, sir.
Sorry. Joe Tucker from UNC Project China. Thanks for the fascinating panel. And many of you touched on the importance of advocacy efforts for those who aren't U.S. citizens, for the huge Fogarty stakeholder group outside of the U.S. that's benefited from global health programs. What are some practical ways that you see low and middle income country folks to advocate? And this low and middle income country advocacy becomes really important, not just for the US, but for advocating for global health in their own countries. And I'd be interested to hear your thoughts on this. Thank you.
Thank you very much. So, Victor, you got Richard, Richard, you got the,
Mark.
sorry?
I think Mark
Richard gave the first question, Mark, to you.
So, Richard,
Cut steep.
I think you make an excellent point. First of all, I think because of the results those organizations have shown, we're nowhere near the point of those cuts being enacted. So you have to go from a budget, which is a policy document, to an enactment. And I was just on the Hill, and I actually do have to leave at 10:30 to go back to the Hill. I don't think we're done. But I would say that, you know, from a member's perspective, cutting X, Y, or Z, you have to say why you get so much more value for money. What are you actually losing there? And we are not particularly good at showing the clear value for money. And I would say that if we don't get better at global health, of bringing coherence from basic research to implementation to equity, and why each investment is a high value for money, and why those cuts are so dangerous, we're actually not going to do well. And I don't think we're communicating these things very well. And if you look to 2019, we have the Global Fund, Gavi, African Development Bank, and World Bank replenishments in 1 year. You know, if there's not coherence, and if we can't explain all that, it's easy to cut here, you know, 15, 20%. And we have to show why we can get better value for money for that 15 to 20%. I would also relate it a little bit to the comment on global health equity, because, and I will use Brexit, which you know very well, and the 0.7. So if you look at official development assistance, the reason it stayed somewhat stable is basically because of the increase from the United Kingdom and the Gates Foundation. Otherwise, we're seeing 15, 20% cuts, and development is what funds global health. The people who advocated for Brexit have shifted to go against the commitment of the current government to maintain 0.7% for development. And they're using the same playbook. Try to find where there's waste and say this is all wasted money. And secondly, and this relates to the disparities, why are we sending money over there? We'll just take all that money and put it in our National Health Service, because we have disparities here at home. And if you can't explain to a member in Ohio why investing globally matters more than putting the money as you're cutting Social Security and health programs in their community, we cannot succeed. So you really need to shift the arguments on why these investments matter, why they're at home. And you saw the comic relief last week and 2 weeks ago in the UK. It succeeded tremendously, but they started for the first time with what their money was being raised to do in the United Kingdom, and then went on to what they were doing globally. So we need to be much smarter at how we're doing things, and much smarter at making the case for why these investment matters, and how we're maximizing every dollar, pound that's given for maximum value. Because most of them look and say, you should be able to absorb a 10, 15% cut.
Victor, did you want to respond to Richard's comments?
Richard, I couldn't hear you very well, but I presume it's you are reading the letter that we sent to our members, our public position. I can tell you that we spent enormous amount of time thinking through this issue, not only ourselves, with our council, with our members. Really what we're trying to say is what I said. First of all, we are, in fact, an advisor to the nation and to the government. So the government has to be able to find us not as an adversary, but in fact someone whose advisor will listen to, which simply means that we can't take public adversary positions on things which are not science-based. And there are many policy issues which are not science-based. But we said when it comes to science-based and when it comes to evidence-based, particularly in issues, we'll definitely speak up. Now, I find that in our unique position, as you know, importantly, because I just recently had this experience, which is a good one, that we're able to go and see all the senators and the US and the Trump administration discuss issues, in this case of the American healthcare issues. And as you might have seen, we wrote a very important paper with 20 such reports on this. If we were to take an advocacy position, which our organization is not, the doors could be shut on us so that we're not able to be able to actually give them the very important issues evidence-based. So effectively what our letter said was that we'll speak up for science, we'll stand up for the science-based issues and reports, but we will not play an advocacy or critical position on non-science policies. And that, I think, is what we're trying to say.
Thank you, Victor. And I'm sorry for the folks at the mics. We're going to run out of time because this session has to end at 10:30, so I apologize. But I just want to ask Trish and then Hester. Hester, you'll have the last word. Trish, how do the question about how we argue to a domestic audience about why international investments are important, what advice can you give?
Well, I think, firstly, it's a multi-pronged approach. I think the arguments about economic security, global prosperity, and also just the humanitarian issues are really important. Just speaking from the question, there are many interventions, particularly in low and middle income countries, that have real applicability to the US healthcare system. So I really think looking at that is very important. So I think it's really having a multi-pronged approach, being able to tailor and target the message to your audience. But I think, we cannot deny that in this world, each and every one of us, our welfare is inextricably linked. And I think how we create that message to people is challenging. And probably the most important examples is in infectious diseases. I mean, I was in Australia at the forefront of the H1N1 epidemic, and just to see your colleagues in the ICU on a ventilator, it kind of brings it home pretty clear. And as we recognise, these are not esoteric options, as Dr. Shao presented. These are real opportunities. So I guess it's how we communicate that message effectively.
Hester, sorry, it would be the last word. I'm sorry, Victor. Hester, from as an African woman, what arguments are you giving to the West in terms of why we ought to be engaging with our international investments? The question that was posed versus domestic.
I think it is critical that partnerships and collaborations continue, and the challenges across Africa is the access sometimes to evidence. So what we've seen in so many of our collaborations is that we would have the evidence coming from the developed country, working to contextualize that in our area, and then really promoting in terms of why it is needed that we should have these partnerships. And that's probably, when we look at funding from sources from developed countries, is that when we say $100, one would think in the developed world, what would that do? But take that to Africa, and I can assure you we can do a lot with it. We have learned to do so much with actually little resources. And I think it's that co-learning and co-sharing that I think really brings the value in the collaborations and the partnerships.
Yeah, there's lots we can learn from each other, indeed. Mark, Trish, Hester, and Victor, you've given us a great deal to think about. You've given us a way to communicate issues we need to champion. On behalf of all of us here, thank you very much for taking the time out of your busy schedules.
Sorry, Victor, I had to. I was just going to say, and we can do that at the next.